basically the topic of my presentation is involvement of genetics in poor outcomes in anticoagulation therapy. Just to give you some background to thromboembolism. The incidence of thromboembolism is rising, and that's partly because of lifestyles, and also partly because people are living longer. And the first line therapy for thromboembolic disorder is anticoagulation. And warfarin is widely prescribed as an oral anticoagulant for treating and also preventing thromboembolic disorders. So thromboembolism, thromboembolic disorders, we're talking about blood clotting disorders, things like DVT. And also there's ample evidence to demonstrate that warfarin therapy decreases risk of stroke by about 2/3 in patients who have atrial fibrillation. So atrial fibrillation is a form of cardiac arrhythmia. And in the West, about 1 to 2% of the population are on chronic therapy with warfarin. So for example, a place like the UK where I come from, which has a population of about 15 million people, just about 1 million people on chronic therapy on warfarin. But that pales into insignificance, where about 2 million people alone in the US start taking warfarin each year. So clearly, warfarin is one of the most commonly prescribed drugs in clinical medicine. And this is data from a recent meta-analysis demonstrating the effectiveness of warfarin preventing stroke in patients with atrial fibrillation based on data from large randomized clinical trials. The problem with warfarin, however, is the complexity with dosing, as to how to start a patient on a particular dose for anticoagulation therapy. And this is partly because of the narrow therapeutic index of warfarin, and also because of nonlinear dose response, which means that small changes in dose can transform into quite large alterations in anticoagulation response with a time lag. And what it means is that anticoagulation response is realized several days after the dosing event. Another complexity with therapy with warfarin is the wide variability between in warfarin dose requirements between patients. And this is a particular challenge, as I'll explain to you later, in terms of the difficulties associated with initiating patients on warfarin therapy. The major outcome of warfarin therapy is bleeding. And warfarin is consistently in the top 5 in the league table of adverse drug-related events. And 1 in every 10 hospital admissions are due to bleeding associated with warfarin therapy. So clearly, the major concern about warfarin therapy is bleeding due to excessive anticoagulation, making the blood too thin. Now, anticoagulation response to warfarin is determined by the INR, international normals ratio, which in simple terms is the ratio of the patient's prothrombin time, the time it takes for the plasma clot to turn into a gel, to a reference compound. And both the efficacy and safety of warfarin therapy is based on maintaining the INR within the therapeutic window. And for most sort of type of thromboembolic indications, the target INR is set between 2 and 3. So adequate anticoagulation which is therapeutic. And sub-analysis of a number of different studies has clearly demonstrated that there's a sharp rise in the incidence of bleeding associated with when INR is above the upper threshold of the target range, i.e. 3. And conversely, there's an increase in the incidence of thromboembolic events when the INR is below the lower threshold value of 2. And this is data from an earlier study by Elaine Heilig, clearly demonstrating the effectiveness of warfarin therapy in preventing doesn't have a pointer here, does it? And
no,
look at it back. You don't have a pointer? No. Okay.
Oh. The pointer?
Yeah.
Yeah.
Okay, that's good. Cool. So this, as I said, data from Elaine Heilig's study demonstrating the effectiveness of warfarin therapy in preventing stroke when the RNA is within the therapeutic range. Oh, thank you very much.
This one.
Okay, lovely. Thank you. When the RNA is within the this one. Okay, is within the therapeutic range, the green bar, and the odds ratio of developing stroke rises exponentially below the RNR value 2 when the drug is ineffective, essentially. And conversely, this is data from a different area study demonstrating that the incidence of intracranial hemorrhage, bleeding in the head, increases exponentially if the RNR is above that therapeutic window. Now, patients who are commencing warfarin therapy are initiated on the drug according to fixed dose regimens. And these fixed dose regimens have been developed over the years based on population mean data. Okay? And there are different algorithms for starting patients on warfarin therapy. Okay. So there are different algorithms out there for starting patients on warfarin therapy. So some of them are quite intense. So you have things like 10, 10, 10, so 10 milligrams, 10 milligrams, and 10 milligrams for the first 3 days of anticoagulation therapy. So these are the loading doses of warfarin. Some are more cautious, so you've got 10, 5, 5. Some are even more cautious. You have 5, 5, 5, or 5, 1, 1, or even 1, 1, 1. But it all depends on clinical circumstances, depends on patient's conditions, depends on the physician's preferences. Okay? But what happens normally, as I said, patients are started on these fixed dose loading dose regimens, and then after that you're in the dark. So what happens is patients change the INR, the patient's INR, and then adjust the dose according to the INR outcome. So if the INR is below the lower threshold of 2, then you up the dose in order to get the patient to within the therapeutic range, to stop the drug being ineffective. Or if the RNA is above the point, above the upper threshold of 3, then you lower the dose to bring the RNA down to within the therapeutic range. But this to and froing with the dose and chasing of the RNA can take several days or even weeks in some patients. And this is where the patient particularly is most vulnerable at having bleeds in particular, or having thrombosis because the drug is infective. And this is data from Lanfield earlier, clearly demonstrating that the risk of, or the frequency rather, of major bleeding takes place in the first 4 weeks of therapy with warfarin compared to any other time. So that's where really the problem is at the initiation phase of therapy, to getting patients to get to the maintenance dose, the stable dose. Now, just to go on any further, I'd just like to show you the basic mechanism of action of warfarin in causing anticoagulation. And you have certain proteins, the toxin proteins in the anticoagulation cascade, namely toxin factors 2, 7, 9, and 10. And these clotting proteins are produced in the inactive form, okay, mainly in the liver. And then post-ribosomally, post-expression, they become activated by carboxylation of the N-terminal. Okay? And this carboxylation and thus activation of these clotting proteins is carried out by the enzyme named carboxylase. And in order for carboxylase to activate these clotting proteins, it requires a cofactor in the form of vitamin K hydroquinone here. So once vitamin K hydroquinone is utilized with carboxylase for running the carboxylation activation of these clotting proteins, vitamin K hydroquinone is transformed into metabolite vitamin K epoxide. And then vitamin K epoxide is reduced to vitamin K quinone, and then vitamin K quinone is reduced back to vitamin K hydroquinone. And this two-step process carried out by an enzyme known as vitamin K reductase or vitamin K epoxide reductase, VKOR. So really the job of VKOR, vitamin K epoxide reductase, is to promote the recycling of vitamin K hydroquinone and driving the carboxylation reaction by the carboxylase and activating these clotting proteins for normal hemostasis, normal clotting. And the way warfarin causes anticoagulation, it binds to the active site of this enzyme because of similarities to vitamin K structural wise, and therefore competitively inhibits this reconversion from vitamin K epoxide to vitamin K hydroquinone. And therefore, by inhibiting the recycling of vitamin K hydroquinone, it starves the carboxylase of its essential cofactor. And therefore, this clotting protein, what they call vitamin K dependent clotting proteins, remain decarboxylated and therefore functionally inactive, causing anticoagulation. We know there are several factors that contribute to the variability in warfarin dose requirement between different patients. We know certain diseases, for example, renal dysfunction, hepatic dysfunction, drug interactions can alter sensitivity to warfarin and therefore warfarin dose requirement. We know age is a major confounder in the variability in warfarin dose requirement between different patients. And there's an inverse relationship between age and warfarin dose requirement. And as we age, warfarin dose requirement decreases. And that's because with increasing age, the liver shrinks in size. Okay? So quantitatively, there are less enzymes which clear metabolize warfarin. And also, there are less clotting proteins being formed, so we require lesser dose of warfarin to achieve the same degree of anticoagulation. Additional to age, you have diet, in particular dietary vitamin K intake. And there have been many case reports clearly demonstrating that changes in dietary vitamin K intake can alter sensitivity to warfarin and therefore anticoagulation response. And it's given that differences in dietary vitamin K status in different patients contribute to the differences in sensitivity to warfarin, therefore warfarin dose requirements. However, this hasn't been formally been established because of logistical reasons. It's difficult actually to demonstrate that dietary vitamin K is responsible for the variability. But we know through the mechanism of action of warfarin, as I explained to you, that changes in the diet or differences in diet can influence sensitivity to warfarin, therefore the amount of warfarin you would need to cause anticoagulation to the same extent. Now, of course, in the last decade or so, we've come to realize that genetics is a major confounder in the variability in warfarin dose requirements. I'll come to that in a few seconds. And as you can see here, this is the structure of warfarin. The reason can cause anticoagulation, but structurally, as I said earlier, is very similar. Chromophore here is very similar to that of vitamin K. So you can compete with this vitamin K by blocking onto the active site of the enzyme vitamin K oxyreductase, which was an anticoagulation. But clinically, warfarin is prescribed as a 50-50 mixture, or racemic mixture of two enantiomers, the R and S enantiomer. And that's because you have this chiral carbon here in the chromophore of warfarin molecule. And because of the presence of this chiral carbon, then you have these two enantiomers, the R and S enantiomers. And although two-dimensionally, okay, on a planar, they're inseparable, they're indistinguishable, they look the same. But three-dimensionally, i.e. biological terms, when you're talking about enzymes, they are seen entirely as two different compounds. Yeah. And most of the pharmacological activity of warfarin actually comes from the S enantiomer. So the S enantiomer is about 3 to 5 times pharmacologically more potent than the R enantiomer is. And the S enantiomer is metabolized by a particular enzyme known as CYP2C9, cytochrome P450 CYP2C9. Okay? And the CYP2C9 enzyme exhibits genetic polymorphism. So you have single base substitutions in the gene that leads to variant forms of the CYP2C9 enzyme. So you have these single base substitutions in the gene leading to polymorphisms. These are two common forms of variants of the enzyme, the STAR2 and the STAR3, with much reduced activity compared to the wild type STAR1 enzyme. So in essence, you can have 6 different permutations of the CYP2C9 enzyme polymorphism. So you have the wild type, which in essence gives you 100% activity, with decreasing enzyme activity, depending on which particular form of variant and a particular patient is the carrier. So differences in enzyme activity or reducing enzyme activity translates into reduced warfarin dose requirement. Okay, so a patient who, for example, is homozygous for STAR3 genotype can't clear warfarin quickly enough, and therefore they require lower doses to achieve the same degree of anticoagulation. And we now know also that there are several non-coding polymorphisms for the VCORC1 gene, vitamin K epoxide reductase complex subunit 1, which expresses the enzyme VCOR, which is involved in the recycling of vitamin K in the vitamin K cycle. And again, it's been demonstrated that polymorphisms in the VCORC1 gene influence coumarin dose requirements. Warfarin is a coumarin. And then you have this particular SNP, which has been widely studied, this 1639 SNP, and it's been demonstrated again that if different polymorphisms of the CYP2C9, this particular SNP, the differences in warfarin dose requirements. So effectively you have like the wild type is the GG with maximal VCOR activity, and then you have the homozygous AA, which has VCO, expresses VCO with least activity and therefore least warfarin dose requirement. And this is data from one of our earlier trials demonstrating the impact of C2C9 and VCO-C1 genotype on warfarin dose requirement between different patients. So as you can see here, as an example, patients with homozygous VCO-C1 AA genotype and of the STAR2, STAR3 or homozygous STAR3 C2C9 genotype have a significantly lower daily warfarin dose requirement compared to, say, patients here who are the GG VCO-C1 genotype or who are the C2C9 type genotype. So using this earlier data from this trial, we are able through regression analysis develop what we call a pharmacogenetic-based dosing algorithm. So this pharmacogenetic-based dosing algorithm was able to predict warfarin dose requirement, daily warfarin dose requirement based on patient genotype, as well as other contributory factors which I explained earlier, including patient age and also patient size. In this particular algorithm, it was height. So, can we get rid of the? Excuse me.
Please, sir.
Could we get rid of this? Oh, let's come out to know that. Okay. Oh, maybe it's me then. Okay, apologies for that. For simplicity, this table shows how the pharmacogenetic algorithm actually works. But for simplicity, I've shown here is that the height is the same in the patients, and also the VCO-C1 genotype is the same between different patients. So for an example, if you look at someone who's 20 years of age and is of the C2C9 type genotype, the daily or the predicted daily warfarin dose requirement here, okay, is about 7 times more than someone who's of age 80 years and who is of the C2C9 STAR2, STAR3 or homozygous STAR3 genotype. Okay, so that versus that. That's dose prediction based on the algorithm. But if you could imagine, if you then taking into account differences in height between different patients, different people, and also differences in VCO-C1 genotype, then these differences can be even greater. And since our publication of the dosing algorithm, there have been a number of other trials carried out by other groups of people developing their own sorts of pharmacogenetic-based dosing algorithms. But the problem with all of these dosing algorithms are that they're derived from specific subpopulation of patients. Patients emanating from highly distinct geographical areas. Okay. So in order to develop a pharmacogenetic-based algorithm which is globally applicable, so you can use it in any patient, really. In particular, taking into account race, so taking ethnicity, like people from Asia, people from Europe, Caucasians, and people also from Africa. That same algorithm can actually predict an accurate dose for that individual patient. And this is where we have the advent of IWPC, the International Warfarin Pharmacogenetic Consortium, whereby the IWPC was a conglomerate of 21 centers across 4 different continents. contributed towards the development algorithm by depositing the data into a central repository. And then the IWPC was able to develop a global pharmacogenetic-based dose algorithm, predicting dose based on both clinical features, patient characteristics, and also based on genotype, main two genes, CYP2C9 and V1C1 genotype. So obviously this data was published in New England back in 2009. So as I said, so the algorithm, so IWPC creates an algorithm based purely on patient characteristics, clinical algorithm, as well as a pharmacogenetic algorithm which had which was a mix of clinical characteristics as well as genotypes for V1C1 and CYP2C9. And what this pharmacogenetic algorithm demonstrated, and this data was based on data from over 4,000 patients on chronic therapeutic warfare. And then through the use of the validation cohort of more than 1,000 patients, what we were able to demonstrate was that the pharmacogenetic-based algorithm was much more accurate in predicting dose, warfarin dose, for individual patients compared to the clinical algorithm. Of course, the big question then was, can you translate research data into clinical practice? That's the real challenge here. So the question posed then was, can pharmacogenetic guided algorithms improve the accuracy of warfarin dosing during the initiation phase and reduce the incidence of warfarin-related adverse events, i.e. either bleeding or thromboembolism? So to address that question, two large prospective RCTs were carried out in around about 2010. One trial was called COAG, which was carried out in the US, funded by the NIHLB, involving about 1,000 patients starting warfarin therapy. And the primary endpoint of the COAG study was looking at stability, how patients are stable within the target therapeutic range, as measured by the percentage time within target RMO range in the first months of therapy. The EU-PAC study, which I was involved with much more than I was involved with the COAG, so there was a committee on that, but I was actually got my hands dirty with the EU-PAC study, by recruiting patients from the UK. So the EU-PAC study was funded by the FP7 program, European FP7 program, involved patients. It was a much larger study than the COAG study because we looked at all three different coumarins, which are used for anticoagulation therapy. Warfarin, which is the most common one, but also acetylcholinesterase, vampirocumab, which is used less commonly, but they're certainly used much more so in other parts across Europe, for example, Greece and Netherlands. The primary endpoint of the EU-PAC study was slightly different in that we also looked at the stability percentage time within the target range within the first month of therapy. Now, the results of these trials were actually published in the back end of 2013, simultaneously, with different outcomes. What the COAG study demonstrated was that the genotype-guided warfarin dosing was no better than a clinical algorithm. So these are the randomized trials. The patients randomized to either pharmacogenetic-based algorithm dosing or the standard care, which is the normal dosing that happens in that particular center. Whereas the EU-PAC study, we demonstrated that genotype-guided warfarin dosing was actually superior to fixed dose regimens. And that pharmacogenetic guided dosing improved percentage time within target range, while about 7% on average, which is clinically significant. So the patient is about 7% more stable during that first 3 months of therapy than the pharmacogenetic-based algorithm compared to the standard fixed dose regimens. So they're trying to address this particular issue about the differences in the outcome. There's lots of discussions about why the COACT study showed no difference, whereas the EU-PACT study showed a big difference. Why was that? What we think basically is and because I've been sort of sitting in the committees and for both of the trials, I know that there are big differences in terms of how the study was actually carried out eventually. And so in order to address why the differences between the two trial outcomes, we carried out further sub-analysis of both the EU-PACT data and the COACT data trial. So what we found was, in terms of the EU-PACT data, that genotype-guided dosing actually caused greatest improvement in stability, the percentage time within target range, in individuals with 2 or more C2C9 or V equals C1 variants, an improvement of about 11% in the first 3 months compared to the control arm. Remember when I mentioned about outcomes, you're not just looking at patients who have genetic allelic variants, who have mutations in their genes, but also patients who are normal. Okay? So if you then focus on really who benefits from pharmacogenetic algorithms, pharmacogenetic guided dosing, it's these patients who have genetic mutations whereby fixed dose regimens, the normal dosing, doesn't apply. They get either most commonly get over-anticoagulated during the first sort of few weeks of therapy, and therefore they're liable to have bleeds, which can be fatal, particularly if you bleed in the head. And we also looked at, in terms of the EU-PACT design, and the COACT study design, and what we found that actually the COACT dosing was more accurate in predicting both the maintenance dose, that's when patient becomes stabilized, to within 1 milligram per day, than the COACT for both the dose initiation period and also during the dose revision algorithms. But you also have revision algorithms whereby when the patient is dosed out during that first 3 days, then the dose is tapered based still on genetics compared to standard, which they just become patient INR. And further PK/PD pharmacometric modeling also demonstrated that patients who are homozygous with C2C9 variant alleles, the ones here, actually benefit the most as compared to other genotypes here. Benefit the most from genotype-guided dosing, which is consistent again with what we demonstrated with the EU-PACT data earlier. So we think pharmacogenetic guided dosing is really effective if we know how to report the data which is clearly robust and withstanding. So just to sort of wrap things up, clearly warfarin is effective oral anticoagulant. We know that. Warfarin is the rat poison. Rat poison you put down to kill rats. That's what warfarin is. And effectively, warfarin causes rats to hemorrhage internally, and they bleed to death. So warfarin, is very efficacious as an anticoagulant, but the problem is not knowing what dose to give to the patient. Those early stages when you're starting them on anticoagulation therapy, and it's very much sort of hit and miss. And then the patient is liable to having bleeds, and it's very risky in clinics. Patient can easily die. Okay. so due to excessive dosing of anticoagulation. So we know that current warfarin fixed dose regimens are inadequate, particularly for populations of patients. And we've also learned that genetic polymorphisms of CYP2C9 and VCOC1 gene, as well as other patient characteristics such as age, body size, influence warfarin dose requirements. And we think that genotype-guided dosing regimens for starting patients on warfarin during the initiation phase of warfarin therapy can improve safety, and it can basically pave treatment toward a more individualized approach for anticoagulation therapy. Now, of course, if through pharmacogenetic guided dosing can improve treatment safety, we can then also reduce the frequency of INR monitoring, because you have to monitor patients who are on warfarin therapy very frequently because of clearly the concern, the fear of patients becoming anticoagulated and therefore bleeding, or indeed the drug being ineffective, and patients thrombosis and having clots formed. So again, can itself be fatal. And also clearly through reduced monitoring, you have reduced burden management of patients. And therefore, it's very cost saving. Less monitoring, less time, staff time, clinical medical staff time spent on looking after patients. That's cost effective to the healthcare provider. And of course, the bottom line is, if you have an improved safety for a particular drug, you also have better patient satisfaction, and that's paramount. The patient acknowledges the treatment and they want to be on it because it can make them better. It's amazing that how many patients actually do miss the tablets, or because of concerns they have, or indeed about a third of patients who are eligible for anticoagulation therapy are denied treatment. This is a valuable treatment. People now who are at risk of having strokes or clots can be fatal because of clinicians' perception or fear that the patient could have a bleed if they're put on an anticoagulant. Therefore, instead, they don't give them anything. Or indeed the patient themselves, because they hear, oh, I know what the risks are, I'm not going to go and have this treatment. Therefore, they're really vulnerable in terms of the consequences. Anyway, I'd like to finish there by just acknowledging my colleagues over the years who obviously helped me with what we do in Newcastle, and the various funders who clearly made our research possible. Thank you for your time. And I'm happy to answer any questions you might have. If not here, then I'm more than happy to answer any questions you have later. Okay? I just wanted to double check. The people who are presenting either later this morning or this afternoon, are they here? Okay. After what we do, instead of having gaps in between presentations, if we basically stitch everything together and have sort of a continuous presentation without any interruption, which I'm sure you appreciate. Shall we do that? Okay. But I think it's, what time is it now? 11:15. Right, so which is exactly the right time for stopping to have a break. Okay, so we'll be back here, shall we say, at 11:30 or 11:45? What would you prefer? 30 or 45?
I think we should stick to 11:30 because otherwise we miss the lunch gap.
Okay, okay. 11:30? No, appreciate that. Things have changed. 11:30? Okay, so we'll be back here at 11:30 and resume. Thank you.